Welcome to the Dementia Awareness Week event, Small Actions, Big Differences with Professor Susan Kurrle. My name is Ellen Miller from Willoughby City Council. Before we begin, I would like to thank my fellow officers in Mossman, Lane Cove, North Sydney, Ryde, Hornsby, Ku-ring-gai and the Northern Beaches for their support and promotional activities with regards to this event. The format for today will consist of a 45-minute talk with Professor Susan Kurrle, followed by a 15-minute question and answer time. Questions submitted at the time of registration have been forwarded already to Professor Kurrle. I would now like to do a brief introduction to Professor Susan Kurrle. Susan Kurrle is a geriatrician practicing at Hornsby Ku-ring-gai Hospital in Northern Sydney and at Batemans Bay Hospital in Southern New South Wales. She is the Clinical Network Director for Rehabilitation and Aged Care in the Northern Sydney Local Health District, and she holds the current chair in healthcare of older people in the Faculty Artist Interest Centre on Dementia and Frailty, Successful Aging and the Intergenerational Care. You may also know her from the award-winning series Old People's Home for 4-year-olds, which explored the positive impact on health and happiness of 4-year-olds and 84-year-olds who worked and played together. Welcome, Sue.
Thank you to Ellen and to Willoughby Council and to all the other councils throughout Northern Sydney who've really supported this, this webinar. I think the fact that they've had so many people interested and we've had so many questions or before the seminars, the webinar started, I just think it's a really important area. So thanks everybody for your involvement. Now we're going to see if this works. Okay, hopefully that's working and everybody can see my screen. So I'm going to run through aging and dementia. I think it's, they're kind of intertwined in a lot of ways. So we will, and we'll cover a lot of things. With the questions that Ellen sent me a couple of days ago, I've tried to include a lot of the answers into the presentation, but I will probably run through some of the questions as well afterwards. And look, if we don't get through them all, I can always do something online and send it out to you all. The issue of life expectancy, I think, is really important because a lot of us forget we are an aging society. Every year we're adding somewhere between 3 and 4 weeks to our life expectancy. So every year that you live, you will be living another 2 to 3 weeks. It has flattened off a little bit, but as you can see from this graph, for both males and females, it's still going up slightly. At the moment, men on average will live to 81, women to 85. So bear that in mind when we're talking about issues with dementia and its link with aging. It's interesting because, of course, in the US, the life expectancy is actually going down. And we're still at that stage of going up, but I guess we see what happens as diabetes and obesity come in over the next 10 years or so. So I just want to show you some pictures, a number of different people here. These are all examples of successful aging, and they're actually taken from around the world. Although there are a number of Australians in them, and I would draw your attention to the bottom right-hand corner, Heather Lee, who is currently a world champion walker, who actually lives in Richmond in northwest Sydney. So these are just some examples of successful aging. And I guess I want to know, what do all these people have in common? And what's really important, they're all over 85 years of age, some a lot more. So they've all exceeded their life expectancy. They're all outside and being active and engaged in activities which a lot of people would not consider normal for old people, which is a real worry because basically everything is normal for as long as we live. But the really important thing is that they haven't let their age get in the way of doing what they want to do. And we know with successful aging, it's important to have the right genes. It's really good if your parents have lived a long time because health and longevity are hereditary. but that's not the only factor. What's been really important is to have the right personality. So be a glass half full person, because you will live a lot longer. Being physically active is so important. And if you take one thing away from today, it's be physically active, because that is good for everything. And it's interesting, the British Medical Journal, just before COVID hit, had an editorial on exercising after 85, pointing out that you do really well when you exercise after 85, because the muscles are still very plastic and can continue to improve. So I think being physically active at all ages, and we'll talk a little more about that, also being mentally and socially active. And I guess just logging into this webinar means you're being mentally active. It's a pity we couldn't do it all together as we've done in the past, and therefore be socially active as well. But we're still doing it. That's what's important. Eating and drinking well, and by that I mean a good diet, and I'll mention the Mediterranean diet. But drinking well, plenty of water. But I'm not saying don't drink alcohol. A little alcohol may well be a good thing. Maintaining independence is really important as you get older. Too often we have an older family member and we say, oh, we'll organise Meals on Wheels for you, or we'll organise a cleaner. And what you do, if that person is still able-bodied, what you're actually doing is disabling them by giving them help, because really we all need to keep doing what we should be doing for as long as we possibly can. And yes, if we've had a stroke or Parkinson's or something like that, fair enough, help can be appropriate. And avoiding disease. Now, that might be obvious, particularly currently with COVID around, but that's the reason we push flu vaccinations. We know avoiding disease is very important. I think we've had a really good lesson on how to avoid disease with social distancing and wearing masks and hand washing and hand sanitizing, but also making sure that your blood pressure's checked regularly, your cholesterol's checked regularly, your blood sugar level is checked regularly. They all can be silent diseases when you have bad levels of those. So when it comes to physical activity, what should we be doing? And the prescription is 30 minutes of brisk walking, jogging, cycling, swimming, dancing, whatever you like, but you need to do it 5 times a week. And the reason we do this is it's good for your bones, it's good for your muscles, and it flushes out your brain with oxygenated blood, which I think is really important when we come to preventing dementia. And it just makes you feel better. But it's also important, apart from that aerobic, that oxygen using activity, that we do some resistance training, and that's weight training. A gym program, home programs are pretty good, and you will see the bottom left-hand corner have a set of weights next to your kettle. I think these are 3 kilogram weights, but 1 or 2 kilogram weights are fine. And every time you boil the kettle to have a cup of tea or coffee, do some upper limb exercises. It is a really good way of getting incidental exercise. Sit to stand, so folding your arms, standing up from the chair, sitting down slowly. That is another really good resistance exercise. And it's probably one of the easiest to do, and you don't have to join a gym to do it. Balance training is also really important. If we want to avoid falls into the future, working on our balance is so important. As kids, we're riding bikes, we run along the curb, we do a whole lot of things that encourage balance. I haven't seen an older person try and balance walking along the curb for a long time, but it's doing that sort of thing. We should be doing it. So standing on one leg. We talk about tandem stance, which means standing with one foot in front of the other. That's another really, and holding it for 10 seconds. That sort of thing is really important. When it comes to being mentally and socially active, certainly developing mental activities in social networks. So learning a language. Now that is something we can do in isolation, and quite a few people have. Playing a musical instrument, learning a new musical instrument is really, really good for the brain. As far as activities, social activities, I think of Men's Shed, particularly obviously for men, what we've always called stitch and bitch, which is actually handcraft groups where you join. And years ago, I was a member of one. We did cross stitch. You could do knitting, but it's just coming together to do something together. The best ones I've seen are the quilters. They are amazing, and their beautiful quilts are something else. U3A is fantastic for being both mentally and socially active, and will be even better when we can get back together again. Probus, Rotary, all those sorts of things are great. Becoming a volunteer is something that is really worthwhile, and it satisfies that altruistic part of us. Going out. Now, we can't really do this at the moment, but I purposely didn't take it out of my presentation, going to concerts, theatre, galleries, because actually you can do a lot of these virtually, and I think we need to do more. The last one here is not a misprint. It's get married. We know that if you're a man, you live longer if you live with a wife than if you're alone, and the risk of Alzheimer's disease is increased. It's not quite the same for women, and we all know why, because we spend so much time, I guess, looking after our men folk. When it comes to eating and drinking well, the Mediterranean diet really is the way to go. So there's been lots written on it, lots of evidence it works well, but vegetables, nuts, legumes, peas, beans, lentils, using plenty of the good oils like olive oil, eating fish, and perhaps less dairy and meat, and certainly less processed foods and saturated fats and packaged foods. We've got low to moderate use of alcohol here, which is 2 drinks a day or up to 10 a week, but you have to have 1 alcohol-free day a week. That's the general rule. So you can enjoy alcohol, but I'm not encouraging you, if you're a non-drinker, to take up alcohol. I do want that to be clear. But if you do enjoy a drink, that's fine. Everything in moderation. And I think the important thing is to say it's never too late to start. And this is one of my pin-up girls, the Australian one, Ruth Frith. Pictured here, she's in her, I think, 80s in the picture top left. But she's 100 in the one on the top right, and the bottom one. She still holds the world 100-year-old record. So an amazing person. She took up exercise at 75. So yeah, never too late to start. Okay, so dementia. This is Dementia Awareness Week. That's why we're talking about it. So what are we talking about? Dementia, it comes from the words without mind, and basically it's progressive, irreversible, and it's the syndrome of impaired memory, intellectual function, changes in personality and behaviour, and all of those cause a significant impairment in day-to-day function. Impaired short-term memory is an early sign, but sometimes we see the development of anxiety or irritability or depression before we get the memory changes. And on looking back, you can see that they were developing. So while short-term memory is the most common first sign, it can be a lot of different things. There's quite a bit of evidence now that subtle language changes may also be an early sign. So there's been quite a bit of work done on that, and it'll be interesting to see if we come up with a language test for that. I have been asked, what's the difference between Alzheimer's disease and dementia? Dementia is the syndrome, the catch-all term. Alzheimer's disease is the commonest cause. So, and I'll come to the other causes in a minute, but in Australia, they feel that we've got about 450,000 people with dementia. We don't know for sure because we don't have a prevalence study, but we are working on doing one at the present time. The thought is there will be at least 900,000 people with dementia in 2050. About 1,900 new cases a week. And at 65, 1 in 12 people have dementia. At 85, at 80, it's 1 in 4. At 85, and remember that's women's life expectancy, it's 1 in 3. So you've still got a 2 in 3 chance of not having dementia. At 90, it's 1 in 2, but then it doesn't seem to get much higher. It's really important to note that dementia is the highest cause, it's the leading cause of death for women in Australia. It's not breast cancer, it's not heart disease, it's dementia. And it's the second highest for men, and I expect it won't be long before it's also the highest for men. Yet you look at the amount of research and attention that's paid to dementia as to other diseases, which can also be fatal, but it's important. And don't forget the approximately 25,000 people under age 65 with dementia. My youngest patient was 31 and 6 months pregnant when she came to our clinic. She had a genetic mutation. She was very, very unlucky. Interestingly, her parents didn't have it and her baby didn't, which was wonderful. But it just shows it can start quite early. And I certainly see a number of people 10 to 20 years younger than I am in my clinic at Hornsby. Younger onset dementia is certainly, an issue, but not nearly as common as when you get older. Commonest causes in Australia, Alzheimer's disease by a long way, and that's why often dementia and Alzheimer's are used interchangeably. In Australia, Alzheimer's disease is around 70–75% of dementia, along with vascular dementia, which is a bit less common, but as you get older, you often get a mixed dementia, which is here is the third one. Dementia with Lewy bodies, that's important. Now, if you've got Lewy bodies in the back of your brain, you get Parkinson's disease. If you have them in the front of your brain, you get dementia with Lewy bodies. It's quite important. And you see people get very vivid visual hallucinations with it. There's also less commonly frontotemporal dementia, Parkinson's disease with dementia, which is where you develop memory problems well after you've developed Parkinson's disease. And we shouldn't forget alcohol-related brain damage, because if you stop the alcohol, you often stop the brain damage. And chronic traumatic encephalopathy. And someone asked this question about footballers' brain, and we are seeing more and more reference to looking after people after concussion, because we know if you get a hit to the head and are knocked out, you increase your risk of dementia, particularly Alzheimer's disease, by quite a factor. So looking after your brain is really, really important, and footballers' brain may well be an issue in the future. Is dementia inevitable if we live long enough? And the answer is no. And I give you my other pin-up girl. This is Madame Jeanne CALMENT, who is the longest living person in the world. She lived to 122 and a half. I just want you to look at the dot points. She was an amazing French woman. She lived in Arles in southern France. We know a lot about her because Karen Ritchie, who's a Tasmanian neuropsychologist, moved to France, married a Frenchman, and she actually visited Madame CALMENT a number of times before she died. But Jeanne CALMENT took up fencing, the sporting sort of fencing, at 85. She rode a bicycle till she was 100 and couldn't. The gendarme in Arles took it away from her because she had visual problems due to macular degeneration and was running into things and people. She lived alone up 3 flights of stairs until she was 110. She drank a glass of port wine, apparently a generous glass of port wine every day. She smoked 2 cigarettes a day, but always smoked them outside, so went up and down 3 flights of stairs to do it. And she ate a kilogram of dark chocolate, and I mean dark chocolate, every week. She did give up smoking at 100 when she couldn't, at 120, and a lot of people would say, well, she gave up smoking and it killed her. It's interesting, but she couldn't get outside easily when she was living in a residential care facility. She was really into the Mediterranean diet. She ate her olive oil, but she also used it on her skin. And she outlived a number of members of her family, although not obviously her great-grandchildren. But she's a really good example of literally staying quite well until she died. There are some things we can do, particularly for Alzheimer's disease, and these factors also relate to dementia more generally. And I think it's a very boring slide, but it's a very important slide because we can modify about 1/3 of the cases of Alzheimer's disease. Diabetes, obesity, low cognitive activity, so just sitting watching TV, that's not good. Midlife hypertension, blood pressure problems, midlife depression, smoking and physical activity. So 21% of those cases of Alzheimer's disease are due to physical inactivity. So it's the most important thing we can do something about. And it might be a small action to get up and go for a walk each day, but I can tell you it makes a big difference. The Lancet, which is probably the world's preeminent medical journal, saw fit in 2017 to do a commission on dementia. And it's actually, if you want some very boring bedtime reading, but it's very thorough. You can download it as a PDF, it's freely available. But they did this, a report on prevention and diagnosis and management of dementia. And again, bring up the issue of what you can do to prevent dementia and increasing education, physical activity and social contact, and decreasing the factors I already mentioned. And you'll notice hearing loss is in here as well. So this is quite important. And I think we should be getting more of those people who have their hearing aids in their drawers rather than in their ears to put them in, because if you're not hearing properly, you're not getting your brain stimulated, and it does appear to be a factor. The World Health Organization also saw fit to do guidelines on prevention, and these were released about 18 months ago, May 2019, and I think that's really important. They say similar things to the Lancet Commission, and this is just one of the pages about physical activity, about stopping smoking, and remember this is the whole world, where there are countries where 40 to 50% of people smoke, and nutrition. So you can be, if you're eating well, it's a good thing. Does prevention work? It's very interesting. There's a study from Finland, the FINGER study, which is the Finnish geriatric study, but they looked at getting people to exercise, eat well, do lots of cognitive activity, and watch their risk factors, blood pressure and cholesterol. And after 2 years, the group that was doing that versus the control group that weren't, there was quite a big difference in memory, and they actually stopped the study because ethically they couldn't keep going. But it shows that, you know, it does work. And we know from large population studies that the incidence of dementia, the number of cases per 100,000 people with dementia, is going down across the world. In the developed countries. And we think that's probably because we're controlling blood pressure better and people are better educated. But it is interesting. So it looks like the prevention does work to a degree. And oh, I've got that in already. I apologize for that. I put this slide in because I think it's important to talk about what we can do for the brain, and I'm often asked this, and I think that was one of the questions. Tetris used to be a Game Boy game, is a really good one on the computer for the brain. Chess is good, and I've got U3A there as well. I've mentioned diet when it comes to prevention of dementia, and I think that's really, really important. But there's also, people ask me about curcumin. Curcumin's the yellow pigment in turmeric. It's what stains your blouse if you get some curry on you. It seems to have an anti-inflammatory, anti-cholesterol, anti-dementia effect. And so there's a lot of work going on, and you can actually buy curcumin tablets. I don't take them yet. I'm waiting for a little more evidence. I'm also often asked about HRT. We know that estrogen from menopause improves memory. Unfortunately, there was a study done about 18 years ago, the Women's Health Initiative study, that put women on HRT at age 70. Now, menopause, when you start to lose estrogen, you don't make it yourself anymore if you're a female, that's 50, age 50. Yet, we put these people, these women aged 70 on it and wondered why they had problems. And there definitely was a slight increase in breast cancer in that group of women. Now that put people off HRT all over the world, which was not a good thing. There've been lots of studies since then that show that it actually, taking HRT from menopause, so you have to go on it around menopause, that it decreases mortality, it decreases heart disease, both cardiac failure and coronary artery disease. There is not an increase in blood clots, which has always been a worry, or in stroke. The only very slight increase was in cancer, breast cancer, and it was very, very small. We also know that the non-steroidal anti-inflammatory drugs, so the Brufens, the Celebrexes, they seem to have a protective effect because being anti-inflammatory, it seems they slow down inflammation in the brain, which is one of the underlying causes of the changes that occur in dementia, and particularly in Alzheimer's disease, but also in the other forms of dementia. And we know that people who've taken non-steroidals for 6 months cumulatively probably drop their risk of any form of dementia by about 20%. And for people who've taken them for 2 years in total, it drops to about 60%. So it's quite interesting. It's pointless to start them once you've got any symptoms. You've got to do them in the 20 to 30 years before symptoms come, because with Alzheimer's disease, you often get changes in the brain 20 to 30 years before you get any short-term memory problems or any evidence of it. And that's just a pictorial view again of dementia, of prevention. And it's prevention of dementia, but it's also prevention of osteoporosis, bowel cancer, heart disease, blood pressure problems. If we do our exercise and eat well, it benefits us in so many ways. Now, research in dementia is really interesting. I think it's important to say we still don't know what causes Alzheimer's disease. It's 116 years since Alois Alzheimer first described Alzheimer's disease. But we still don't know what causes it, and we don't have a cure. And every time you hear about a research breakthrough, it relates to rats and mice. And let me tell you, rats and mice do not get Alzheimer's disease naturally. They have to be genetically engineered. So it does worry me. And we've seen thousands of drugs that look fantastic in mice, but do not work at all in humans. There's been more than 200 negative trials at phase 3 level. So that's when you're trying to see if they're effective. They've been through all the safety and tolerability bits, and then they fail. Even recently, 3 trials that were looking particularly at the amyloid side of Alzheimer's disease. So it's one of the proteins that's laid down in the brain. They were all stopped due to negative findings. There is one at the moment that's quite interesting called ANAVEX. We're actually doing that study at Hornsby. It modifies the changes in the brain rather than curing it. It actually addresses neurodegeneration, and it works by activating mitochondria. They're the little powerhouses of the cell. They're what generate energy in all of our cells. It seems to improve the function of those, and we're certainly seeing some interesting results in that particular study. So watch this space. The other one that's interesting, and again, we're doing this at Hornsby, so I know all about it, is a Chinese medicine. It's a triple therapy. It's ginkgo biloba, ginseng, and saffron. And that's particularly for vascular dementia. So that's ongoing. We don't have results yet. Initial results look good, but then they have in a lot of other trials too. We live in hope. There are a lot of other advances though in terms of dementia. We're getting much closer to a blood test. We know you can look at cerebrospinal fluid, so do a spinal tap and have a look at the fluid. That's probably reasonably reliable, but it's not perfect. It's interesting, we also, in some other areas, we know that if you don't sleep well, you're more likely to get the changes in your brain that do lead to particularly Alzheimer's disease. Another thing to mention is post-operative cognitive decline. So this is what happens after an operation. You often see people get very muddled and confused. And as one of my patients said, she was right away with the fairies. And she was aware of that for about 2 days after surgery. That you see, and people who get that are more likely to go on to develop dementia, particularly if they're taking some drugs that may make them more muddled. And I'll give you an example, Lasix, a fluid tablet, or prednisone, which is a steroid that we use. Both of those on their own can make people more muddled because of their effect on the brain. We know that if you have a decreased sense of smell, you're more likely to develop cognitive decline. That's not for footballers who've been knocked out or people who've actually had their head hit so that they lose smell because of that. but it is quite important, that impairment in smell. And as I mentioned earlier, hearing impairment also increases the risk of all-cause dementia. There's also been some really interesting work done on the idea of resilience and resistance to dementia. So resistance is how do we avoid the disease? So that's these people like JEANNE CALMENT, who lived to 122 and did not get dementia. And then you've got those people who do get disease changes in their brain, but don't get the symptoms. And we know from a very big UK study that's been going on now for almost 40 years, where they see people during their life and then they collect their brains after death. And we know that about 1/3 of those people had changes in their brain and they had dementia before they died. 1/3 of people had changes in their brain, but no dementia before they died. And 1/3 of people had no changes in their brain, but did have dementia before they died. So it's not, we still don't have the answers, but I think it's important that there are people with quite significant changes in their brain who don't actually get the disease, they don't get the symptoms, and it's working out what's different about them. We need to know that for the future. Now, changing tack a bit with research, but this is still research related to people with dementia. What's the best model of residential care for people with dementia? So for the last 6 years, till the end of last year, I led a large research centre looking at cognitive decline really across Australia. And this was one of the very interesting pieces of work that we did, asking how do we best look after people with dementia? And is it the traditional nursing home, institutional style, hospital-like wards, or is it much more the group home, the domestic home-like style, which is what we do for younger people with disability? So we looked at 541 older people across 17 aged care facilities in 3 Australian states. We looked at those in the home-like, the cottage model of care versus the standard institution. And you can see at the bottom the pictures. You've got your standard institution on the left, a more home-like environment on the right. What we know is that people in the home-like environment showed higher levels of quality of life and quality of care as rated by themselves and their family members. What was very interesting, they come into hospital much less often, and they have much lower psychotropic medication use, so the drugs that affect the brain. And they cost either the same or less than the traditional institution. So I would ask, why on earth aren't we doing this much more? And I think it is really important. We have really good models in Australia and around the world, and we're trying to encourage those big aged care providers to do more of the cottage model of care, and you can retrofit a standard institutional model to do it. But I think I know where I would like to be, and that's not in your standard institution. What was important to the residents, and this is what a cottage model of care, the group home idea is, small size, anything between 6 to say 14 residents. You can get outside at any time, day or night. Staff members are allocated to residents, so you've got a continuity of care. Meals are prepared within the unit, within the cottage, within the apartment. The kitchen's in the middle, and this is an example, and this is actually where my mother is. She's sitting there folding washing in the third picture along. But they cook the meals in the kitchen, you can see there, so when you go in, you can smell what's for lunch or for dinner. The residents get involved in that preparation and in other household tasks like hanging out the washing. So it's much more normal than your standard institution. Okay, finally, and I'm just looking at the time, management of dementia, because I was asked a lot of questions about this, and it's very hard in 45 minutes to cover everything, but I will mention this. Now, this is much more probably for healthcare professionals, for clinicians, but as part of the research centre that I mentioned earlier, we actually developed the first Australian clinical practice guidelines for dementia, and you can download them. You just actually have to Google Australian clinical practice guidelines. But we developed them, unfortunately, it's over 4 years ago they were released, but they're probably still gold standard. We're looking at updating them to a degree, but there are 109 recommendations covering everything from diagnosis to death in all settings, and I think really give you the latest evidence base. So if you actually want to know what we should be doing, they are available, freely available for download. The web addresses there. We not only did guidelines for professionals, we also did guidelines for the public. And if you like, this is the lay companion guide, the consumer companion guide to the clinical practice guidelines, and it's in much more easy to understand language. It doesn't cover all the areas to quite the degree, but it's important it's there. It's also downloadable, same place. These are some examples. The EBR stands for evidence-based recommendation. And these are things that a lot of people don't know. And I think we should be doing this. We know the evidence is there. People with dementia living at home in the community should be offered occupational therapy interventions. And it covers environment, technology, a whole lot of areas. We know that works. We know it keeps people at home longer. It reduces stress, improves quality of life. We're not doing it enough, but we know that we should be doing it. The other really important one, and it brings me back, and I'm sorry, I'm like a broken record here, but people with dementia should be strongly encouraged to exercise. So it's coming back. Physical exercise is important right through life. So even when you have a diagnosis of dementia, you should be doing the exercises. Why? Because it actually reduces functional decline and slows the progress of the disease. So you can't lose doing it. And I think it's important. We're saying an exercise physiologist or a physio should have some contact with all people with dementia and just set up a simple exercise program. We also know that carer and carer support programs are really important. And I was asked about that. As one of the questions. There are carer support programs out there. My recommendation is always go to the Dementia helpline, speak to them, and they can tell you where Dementia Australia has carer support services and where there are other ones. And that number is it's 1800 100 500, but we can again send that out for those people that are interested, or just Google, it's the Dementia helpline. So we know that supporting carers is really important. Finally, well, not quite finally, I have two more things to talk about. Current treatments, and this is my way of treating people that I see who come to my memory clinic in the early stages of dementia, or maybe later on. And I see people both here in Northern Sydney, but particularly I see a lot of people down the south coast of New South Wales at Batemans Bay and Maria. Physical exercise, again, sorry, but I'll keep reiterating that. Occupational therapy interventions, I've mentioned those as well. Cognitive training, so keeping your brain active, doing games, you know, crosswords, Sudoku, find a word, all those sorts of things. I've got vitamin E in brackets because there is some evidence it probably does slow functional decline, but it sort of comes in and out of favour. Support and education for carers we know is really important. Then we actually get on to the medications. So it's all those other things that are actually really important first. We know that there's drugs that help the symptoms. They're called the cholinesterase inhibitors. Donepezil or Aricept is probably the most commonly used. Rivastigmine is a patch, which is also very effective. These drugs are really good as a trial. A third of the people do well on them. A third stabilise, and as far as I'm concerned, that's doing well. And a third, they have no effect at all. But I feel everybody does deserve a trial of these. Later in dementia, in particular Alzheimer's disease, there's something called memantine or Abixa, which can be added to help anxiety and function. I think it's important to plan ahead after a dementia diagnosis. But look, to be honest, we should all, dementia or not, we should all be doing this, other than perhaps the working. Have you all done your enduring guardianship and enduring power of attorney agreements? Who will make decisions for you if you're knocked off your bicycle or run over by a bus and are unconscious or unable to communicate for a while. You may get better, but during that time you can't communicate. Have you decided who will help, who will make decisions? Very important to do both of those. Most of us do wills, but quite a few people don't. Doing a will is important. We talk about advanced care directives, which is what you want when you get older or you get to a stage where you can't make decisions for yourself, and you link that with enduring guardianship because that person would be helping make those decisions. So it might be that you don't want to be kept alive if you have a major stroke or a very bad head injury, but you do want everything if you have a heart attack, including operations, bypasses, those sorts of things. I think it's important to think about what you do actually want. What you want now, it may change when you get to 93. And for people with dementia who are working, we say start to slow down. You probably can still work for a while, particularly in the very early stages. Consider simpler tasks and go part-time and look at retiring. But I think it's important to remember that certainly with people I see in the memory clinic who are early in their disease, they've been working perfectly normally. They see me, I give them a diagnosis, they've got a label, but they're the same person as they were the day before, and they can keep working for a while. And I think that's very important. I do want to mention driving. It's a real issue, and people often ask me about this, and GPs will often refer to geriatricians to talk about driving because they don't want to be the bad person. And I have to admit, this year I've had 3 people decline to come back to me because I did say they were to no longer drive. And I'm pretty easy on driving. I send people off for on-road tests, and if they pass that, I'm happy for them to drive. I don't take on board the fact that they've driven for 60 years without an accident. Probably the male driver that hit Sophie Delizio, and you would all know Sophie Delizio's story. He probably hadn't had an accident either, but something went pear-shaped. And in fact, she was hit twice by elderly drivers. So I think we have to be very careful with dementia. We do know if you've got a diagnosis of dementia, you are meant to self-report to, in our state, the RMS, to the driver licensing authority. No one ever does. But what we say is GPs will look at, when you do your medical form, have a restricted license, which means driving in daylight hours, driving within 10 kilometres of your home address, that sort of thing. But I say to people who I see, start to think about retiring from driving, start to think about alternatives. Look at public transport or volunteer transport, taxis, Uber. If you've got a care package, they will do it, family members. It's really important to think of alternatives. And we encourage self-limiting, so driving less and less, stopping, going and handing in your license and getting an RMS ID card, which you can do fairly easily. What can we be doing to improve things for the future? This is just a plug for our Northern Sydney Dementia Collaborative, which is our the local health district, so all the hospitals. It's the primary health network, so all the GPs. It's a number of NGOs, so non-government organisations. It's Dementia Australia, and particularly now it's the councils coming in and doing what I'm doing today is part of the issue of let's make us much more dementia friendly. We have people with dementia and consumers advising us. We developed a memory brochure, which is available for download, which is particularly for Northern Sydney. We developed, or the primary health network, so the Sydney North Health Network developed a discharge service for people with dementia from hospital, because this is what our consumers told us we needed. You can't send people from dementia who live alone home without a bit of support. So that's been commissioned and is running pretty well. I do want to mention dementia-friendly communities because we're all heading in that direction. And it's a place where dementia is known, it's accepted, and where people with dementia are still included and not stigmatised and excluded. We're looking at trying to make council offices, banks, train stations, doctor's surgeries, libraries dementia-friendly. We're having a few hiccups at the moment because Dementia Australia keep changing how we should be doing it, but I can tell you all the councils in Northern Sydney are working towards it, which is really, really important. And the idea of becoming a dementia friend, so that we all know what dementia means. Because if we live long enough, we're either going to have it or live with someone that does have it. So I think it's very important we know what we're talking about. This is a dementia-friendly men's shed, where you have to be obviously a little more careful with your lathes and your drills and your saws, but it is really something we can be doing. Finally, I have been asked a lot about intergenerational care, and those of you that saw Old People's Home for 4-year-olds, I think would understand it had an amazing impact. I don't think any of us involved in the program thought it would have as much, but we've known about intergenerational care for quite a long time. We've sort of looked at it in the past, and the idea of bringing children and, well, different generations together, either playgroups, play schools, any of those areas, because we know it is good for older people and we know it's good for children. And there are a number of ways you can do it with co-location, visiting models. We obviously had children visiting the aged care facility in the first program. Watch this space for the second program, which will be a little bit different, COVID permitting. What we did show, though, in that ABC series, over 7 weeks, the effect of 10 4-year-olds on 11 people aged between 78 and 95 was amazing. These were people who hadn't gone out, they hadn't walked much, they were depressed, isolated. There was a statistical improvement, significant improvement, but also you saw a clinically significant improvement. And I can tell you the effect was sustained over 12 months and longer, which I think's been really important. How do we do that? Particularly in an age of COVID, we're working on it. But we're doing a little more, perhaps using iPads and things, but it's a very important area that I think we need to promote. How do we promote early dementia diagnosis? And we certainly say that in our clinical practice guidelines. Memory loss is not a normal part of ageing. Go and talk to your GP if you're worried. Northern Sydney has a lot of memory clinics. There's a lot of ways we can have a look and see how your brain is going. Quite often it's the worried well we see. But if you speak to your GP, I think that's really important. Carers groups I've already mentioned, and the dementia helpline, 1-800-100-500, really, really important. What are the initial symptoms? I think I mentioned short-term memory loss is the most common. Look, if you're worried because you walk into a room and can't remember what you went in there for, that's probably normal. If you're worried about not remembering a name of something for a short period of time, that's a normal age-related change. It's when you don't remember the person or their name that you start to get worried. And once you've lost your car in the car park more than twice, I would say you're either very careless or you may be developing memory problems that could be a dementia. So it's worth looking at. There is no blood test available for the diagnosis yet. In fact, the only way of making a definite diagnosis, particularly of Alzheimer's disease, is to take a piece of your brain out and look at it. We talk about probable and possible Alzheimer's disease, but we are looking forward to there being a blood test, and particularly to there being something that we can do earlier in life for people who, like me, have a family history of dementia, where we can have a look and see how is there the likelihood you might be developing dementia. Certainly it's unusual in early ages. It's much more common after 65, but I did say there are young people getting it. I was asked about it being genetic, if it's in the family, and there's certainly a slightly increased risk. As a population living to 85, our risk generally is about 36%, a bit over a third, that we will develop dementia. If you have a close family member, mother, father, brother, sister, child with it, your risk goes up to about 39%. So it's a 3% absolute risk increase. It's not huge, but if you've got a family member, you should be doing all that prevention stuff I talked about, because that's how you reduce your risk. Does it happen quickly? No, it happens slowly. If you suddenly have someone in your family develop a sudden onset of confusion, it's most likely to be what we call delirium. which is an acute confusional state usually related to an underlying medical condition or you know, a drug reaction. And it's treatable when you treat the underlying condition, and people do get better. However, if you do develop a delirium, either in hospital or wherever, you are a little more likely to develop dementia later because your brain is a little bit fragile. If you're told you have cognitive impairment, that's not dementia. People can have memory problems and have them for years and years and years. How do falls affect an older person's mental health? If they hit their head and get a traumatic brain injury or a bleed around the brain, then obviously it's very serious. But if you've got dementia, you are 2 to 3 times more likely to fall. So it's interesting, but because your visuo-perceptual abilities are less, or you're a bit impulsive. So falling is something we do see more commonly in older people. I'm asked, is there any medication for the 95 pluses to improve dementia? Certainly we know that the medications we use for younger people work. And if I give my mother as an example, she's 93 and she's on one of the medications to help her memory. And I know when it's with she gets a bit worse, so it's, you know, we look at starting it again. It's certainly important. With no proven cure, how can we best build prevention? Look, I think we've talked about that. If I said exercise, 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 and what you eat and how you think, how you use your brain is really important. There's a question which is really interesting. When do you know if someone living on their own with early signs of dementia needs to go into care? I think we all would prefer to live at home, or the vast majority of us would prefer to live at home. And I think our aim, and certainly me as a geriatrician and the aged care service I work with, aims to manage people at home for as long as is humanly possible, because let's face it, most of us want to be carried out in a box. And so putting services in is really important. Often with dementia, people can actually become dangerous. They can go out, they can wander, they can set fire to things. When you get to danger to yourself and others, then you have to weigh up risk of that versus how would you feel if someone put you in a nursing home when you didn't want to go? And I think it's very interesting. We're seeing that people aren't going into nursing homes nearly as much as they were 12 months ago. I would have thought you wouldn't go into a nursing home until you really needed to, and we certainly emphasise that. Put in as many services in the community into the home as you can. Be prepared to pay for it because nothing's free, and be aware that there are risks, and you've got to decide on that risk benefit balance. Would you prefer to be at risk at home or very safe in a nursing home but completely unhappy? It's a very interesting thing. And I think for families that come and say, but you've got to put mum in a nursing home, I say, is that where you'd like to be? Because if you model the behaviour, if you do this with your mother, your children are watching you do this to your mother. You will find the same thing will happen to you. And that's certainly been borne out. Yeah, look, Ellen, I'm just looking. Preventing repetitive behaviour. There's a great one, whistling in residence. Look, we had a panel at a conference I was speaking at yesterday on the behaviours that can occur in dementia, and they call it inappropriate vocalisation, which is actually shouting out. But whistling or singing, they're all quite difficult to manage. I would always say if you are in a residential care facility or if you're at home and you're looking after someone who has dementia and is having some of these behaviours or symptoms associated with their dementia, ring the Dementia Behaviour Management Advisory Service. Again, you can Google it. It's a free service. The number is 1-800-699-799. I know it off by heart because I use it quite often. And they actually visit at home. They're Commonwealth funded, they're free. They can provide some advice, and certainly in residential care, I think it's very important that we look at that. What can a hospital ward do to prevent inpatient falls for a person living with dementia? I can tell you we've studied that in at least 4 trials I've been involved in, and we haven't got the answer yet. Falls in people with dementia are really, really difficult to manage. And often we say, look, put them in hip protectors, wrist guards, so that if they do fall, hopefully they don't break anything. So the Dementia Behaviour Management Advisory Service, otherwise known as DBMAS, the number is 1-800-699-799, and they are there. They're actually a 24-hour service, although they won't come that quickly, but they can visit at home, but they will go through the issues and give you recommendations. And I personally have a very strong rule for myself that I wouldn't start someone on a medication to change their behaviour until I've had a really good talk. There was one about COVID-19, and I thought it's interesting. There hasn't been a lot of questions on that, and I really haven't sort of mentioned it too much. But about aged care facilities, some are allowing visitors, some are not. And I think that has been a real issue that needs to be looked at. I have the very interesting situation where my mother is in a facility that does allow visitors. So I was, until 3 weeks ago, when we were banned by Dr. Kerry Chant from visiting, because we live in the Sydney area, and that's now been lifted. I did see my mother on Monday, which was good. I was allowed to visit every day if I wanted to. I was temperature checked. I had to show my flu vax, you know, answer the questions, hand sanitize and wear a mask. But I was able to go and see my mother. My mother-in-law is in another facility and they have not let anyone in. My poor father-in-law has actually pushed.
Question come in here, Professor Kurrle, if you could answer this one for us. For those of us working in customer service, are there any quick tips for making someone with dementia as comfortable as possible during a customer service interaction?
I always say the smile, a friendly smile, and I know it's hard with a mask on, but you can still see someone's eyes crinkling behind a mask. I think the smile is so important. Body language is really important. Being at the same level as the person and using very simple language. I know we shouldn't be treating them like children, but I think we need to be very aware that for someone with dementia, the brain doesn't work as quickly, you get confused more easily. So providing that gentle reassurance is so important, but a smile goes absolutely miles. Now, it's harder behind a mask, and I always would say once, a touch is also really, you know, just touching them on the arm. Now, clearly we probably can't do that as easily now. But I do find even that smile and the body language that says you're welcome and I've got time for you is really important.
Fabulous. Just one or two more questions because we could go on all day. This information is so fantastic. What support is important for families to cope or understand or grieved over loved ones who are diagnosed with dementia? So I suppose there's a carer support information.
It's knowing, it's knowing you're not alone. And carer support is really, really important, is having that, to have some support around you so all the family understand that, you know, mum or dad or whoever has a dementia. That will be gradually progressive. Putting steps in place, making sure you've got enduring guardianship, enduring a power of attorney, all those things that can make life much simpler later on, that you've had an aged care assessment if that's appropriate and we need it down the track, that all your other conditions, your diabetes or your blood pressure, that they're under control as well. And then looking on the positive side, and getting out and doing things. We used to say tick off the things on your bucket list. That's been really hard, although people can still get out and do things. But I think having the support of people around you, knowing that there is support out there, go to the Dementia Australia website. You can go to a number of different, there's quite a lot of information out there. In fact, there's sometimes probably too much. But it's knowing that you are not alone that I think is really, really important. And then working out what activities you'll want. If your husband's developing dementia and he's a golf fanatic, make sure his golf companions know and that they they help him score. It's all those little things you can do. I've got a man who scores really badly on his mental state testing. So on his, you know, his memory's terrible, but he is a brilliant tennis player in his late 80s, and he still plays tennis. His mates come and pick him up and drop him home. He hasn't lost that ability. Having those friends, talking about the diagnosis with your support crew, I call them, which is family and friends. I tell you, you know very quickly who your friends are when someone in your family develops a diagnosis of dementia. And I can say that with both a mother and a grandmother who had dementia. And it's funny, the people that drop off, but also the people who come out of the woodwork to